Okay, so I guess that you can see the screen now. Okay, again, I would like to welcome you to this new session of our course. We are going to cover the ocular pathology, and let's start by a little bit of an introduction. So, do you think that the ocular pathology is an easy topic or a hard topic? And for the exam, is it important or not important? Well, there are some good news and some bad news. The good news is that if you are applying for the ICO exam, there will be only 12 questions. So only 12 questions, and they will not be like extensive 20 questions like other topics. So only 12 questions for the ICO exams. And if you are applying for other exams, such as FRCS Glasgow, the second part, you are unlikely to be asked in histopathological slides. So if you are applying for the ICU exams, you will find histopathological slides. So this is the good news. But the bad news is that the questions are really tough. That requires good observation. They require an eagle eye even to in order to pick the clues in the histopathological slides or in the gross specimen. So you need to be very careful when dealing with these questions. Okay, so the problem about the pathology questions is that they don't merely ask about diagnosis. If this was the case, it would have been easy. However, you have to have a certain mindset in order to. Can you hear my voice? In case of the ICU advanced exam, it will be like around 6 to 8 questions, as they are divided into two themes: the ocular pathology and the tumors. Okay, so back to our topic. When you are thinking of the ocular pathology in the exam, it is not about only the diagnosis, but you will need more steps in order to reach the diagnosis. Like, first of all, you need to identify the tissue, then you need to identify what is the stain, the pattern, and finally you reach a diagnosis. And here is a very important trick that sometimes in the exam they bring you the tissue. They tell you that this is a cornea, and or this is an iris or so on, and even they can identify the stain easily. But the pattern here is that no one is going to tell it to you. The pattern is what make you good in pathology, is to recognize the pattern. Okay, and once you reach it, identify the tissue, the stain, and the pattern, you will reach diagnosis, and you will take it from here and know what is the either like any kind of management, or what is the genetics, because genetics can also be asked in this section, especially in retinoblastoma. So as I told you, you need several steps to reach diagnosis, and you need the diagnosis to answer the question in the exam, which is sometimes not asking about the diagnosis only. Okay, so we will build our knowledge in pathology from the baseline. Like, if you don't know anything about the pathology before, we will take it from scratch. So normal ocular tissues histology. You need first to know the normal in order to identify the abnormal. So this is a section for the anterior segment showing the cornea, the normal thickness of the cornea, and the epithelium of the cornea is continuous with the epithelium of the conjunctiva. This is the angle of the anterior chamber, as you know, the iris, the ciliary body, and this is the lens. The cornea itself, you need to know how it is structured, because the cornea is formed of epithelium. The superficial layer will be flattened layer, followed by the wing cell layer showing polygonal cells and resting on a basal cell layer, followed by the desmus and the endothelium. This will be the epithelium. Then the entire thickness of the cornea is mostly formed by the corneal stroma. So you need to know what is the relation between the corneal thickness in the stroma to the epithelium and to the entire thickness of the cornea, because it will form like around 90%. So if it is more than that, you will consider that this is a corneal edema. Also recognize the normal pattern of the endothelium, which should be smooth with no warts. This is the angle of the anterior chamber. You should recognize when it is open or it's closed. This is the normal pattern of the iris, showing the posterior pigmented layer of the iris in the posterior surface, and also as well as in the here in this in the ciliary process. The section of the lens is showing the lens epithelium, the anterior lens epithelium with the nuclei of the lens fibers showing the nuclear bow as they are compressed toward the center. The normal histology for the retina, as you see the normal arrangement of retinal layers. And this is a normal section for the optic nerve showing the retinal nerve fiber layer from the retina. And you can see that this is a blind spot. There is no the retina is or the photoreceptor layer is not continuous here in the area of the optic disc. That's why this is a blind spot. Okay, so this is a very, very quick brief about the normal ocular tissue, and this is why I'm just showing them to you in order to see how the normal looks like. Regarding the stains used in the ocular histology, we first started by the commonest stain used. The commonest stain used in the routine pathology is called the hematoxylin and eosin. Hematoxylin and eosin, these are the commonest stain used in pathology. So you can see that there are two stains. The first one is called the hematoxylin. This is a basic dye. It is a basic dye which stains the acidic structure purplish blue. Again, because please concentrate for the MCQ. It is a basic dye. Since it is a basic dye, it will stain the acidic structures, the structures that contains the acid, and they will stain it with a purplish blue. So you see where is here the purplish blue? They are the nuclei. The nuclei contain the DNA. The DNA is the diariboxynucleic acid. So it is acidic. So it will stain it by the hematoxylin because hematoxylin stain the acidic structures. So it will stain the nuclei. It will stain the rough endoplasmic reticulum with their RNA because RNA again contain acids. So the DNA and RNA within the nuclei, the ribosomes stained by the purplish blue, like that. The eosine is an acidic dye. And the acidic dye, this will stain the basic structure. And it will stain it by red or by pinkish red. So it will stain the cytoplasm. It will stain the cytoplasm by pinkish or red. So the eosine is an acidic dye which will stain the basic structure by red or pinkish. The next important stain, which was also frequently used in the histopathology, called the periodic acid Schiff or PAS. This stain is used to stain many structures like glycogen, like mucin, like glycoprotein, like basement membrane, like fungi. So when you see that, if you remember from the basic sciences, when you read that this like Dismus membrane is a collagen type 4 or any collagen type 1, type 2, how did we know the type of the collagen? This is by a specific stain which stain the basement membrane. The basement membrane is usually stained by the periodic acid Schiff and also can be used for identification of fungi, as I told you. Another very important stains, especially for cases of bacteria, is called the Gram stain. The Gram stain can stain the bacteria by bluish color. In this case, it will be called Gram positive. It can be either cocci or bacilli, or it can stain the bacteria negative or can stain it red by, and that time it is called the Gram negative, and also it can be in the form of cocci or bacilli. So this is called the Gram positive, and this is called the Gram negative. Another important stain is called the Giemsa stain. It can be used for the fungi, can be used for the chlamydia. This is for case of chlamydia, and they stain it violet. Also, there is an important stain called the methenamine silver, which will be used for staining the fungal hyphae. And you see it, it will be stained by black. It's called the methenamine silver. The acanthamoeba can be stained with wide varieties of stains, like periodic acid chaff here, or methenamine silver, or the calcoflower white. So these are different stains used for staining the acanthamoeba, as we are going to see later on. So these are the stains, that the common stains used in ophthalmology. There are also some stains that will be used to highlight special substance. Like if there is deposits within the cornea specifically, they will be taking specific stains. Like for example, the amyloid. The amyloid in lattice dystrophy will be stained with what's called Congo red, will stain the amyloid in lattice dystrophy. The presence of Mason trichrome stain. Mason trichrome stain will stain hyaline deposits present in case of granular dystrophy in the cornea. And finally, the mucopolysaccharides present in the macular dystrophy will be stained by a specific stain called Aylsham blue. Aylsham blue. So again, if you see that this is a very common question in the pathology of tissue, and the kind of a stain, you solve the case. So it is, again, recognize the pattern and recognize the stain will help you to reach diagnosis. And finally, the pattern. What is the pattern? When you put the whole pieces of puzzle together, you will reach a diagnosis when you think of what is the pattern look like. Let me give you some examples. In this pattern, this is a skin lesion, and the skin lesions has hyperkeratotic epidermis and taking the form of crater. This is a keratin-filled crater, and this the pattern of the keratoacanthoma. It is a keratin-filled crater. Another pattern when you see the histopathology of multiple bluish cells, homogeneous bluish cells, like a sheet of blue cells. This is the pattern of B-cell lymphoma, and these are lymphocytes. And when you see that, this is a section for the cornea with the back surface of the cornea showing these excrescence. This is a patient and with a corneal edema. In this case, you think of Fuchs endothelial dystrophy, and this is our corneal guttata. When you see this hyaline pinkish deposits underneath the basement membrane, underneath the pigmented layer of retinal pigment epithelium, and this is a section of the retina, you will recognize that this is our drusen. These are a dry age related. Do you hear my voice clear? Please, if anyone hear my voice clear, please let me know. Okay, let me try to change the connection. Hold on. Okay, let me just finish this slide. This is a pattern of Swiss cheese appearance. Swiss cheese appearance, this is a pattern which is recognizable for the adenocarcinoma of the lacrimal gland. And this is the pattern of rosettes, which is present in retinoblastoma. Also, not only the histopathology, but also the gross pathology. The gross pathology, when you see a patient with this kind of lid ulcer, ulcerative lesion with loss of flashes and rolled in margin, this rolled in margin, this will be the okay, so let me try to change the connection. Maybe I am having a weak internet connection today. Okay, I changing the connection. So I'm going to repeat the pattern again, and please let me know if it is better now. Okay. So regarding the pattern, you need to identify the specific pattern of each slide that is presented to you in the exam by just thinking of the different clues in this picture that will give you a diagnosis. Like, for example, what is this? This is a patient who had a skin lesion, and this skin lesion has hyperkeratotic epidermis, and this epidermis will make the form of crater, and this crater is filled with keratin. This is eosinophilic material, and this goes with the pattern of keratoacanthoma. The next pattern is the presence of multiple blue balls. These blue balls are called the sheet of lymphocytes, and this is the pattern of the B-cell lymphoma. There is a highly proliferation of the B cells. Another pattern is the presence of a corneal tissue with this corneal edema and the presence of multiple excrescence on the back surface of the cornea. So this patient has Fuchs endothelial dystrophy with the presence of corneal gutata. When you see this slide, you recognize that this is a slide for the retina, and this is the pigmented layer, the RPE. Well, and what is this eosinophilic material deposited under the RPE? This is the drusen, the age-related macular degeneration. These are the sub-RPE drusen. And what is this pattern? This takes the pattern of a Swiss cheese appearance. Swiss cheese appearance is the pattern recognizable for the adenocarcinoma, the lacrimal gland adenocarcinoma. And here is the pattern of rosettes. And the rosettes are present in case of retinoblastoma. And not only retinoblastoma, but this is the most common. So retinoblastoma is associated with rosettes. So by recognizing the pattern, you will know what is the diagnosis. And it is not only for the histopathological slides, but also for the gross pathology. Like if the patient has this lesion, this ulcerative lesion with loss of flashes and rolled in margin, this is for basal cell carcinoma. Also presence of a nodular mass present over the limbus with hair follicle. So here is the clue, the presence of hair arising from this mass. This patient has limbal dermoid. The presence of hugely thickened extraocular muscles with sparing the tendons. These are the thyroid ophthalmopathy or Graves ophthalmopathy that we talked about the last slide. You can also present in the exam a globe section. So you may find a case like that. So what can we see here? We can see that there is a mushroom-shaped lesion, and this will associated with the retinal detachment. So this patient has choroidal melanoma. Again, this is how does it look in real globe section before histopathology slide. This is a exudative retinal detachment associated with a mushroom-shaped lesion. This is the pattern that we are talking about. Also, another important pattern is the presence of calcification. So presence of calcifications in enucleated eye in pediatric age group is almost always like a retinoblastoma. So always recognize the pattern. This will help you to reach the diagnosis and solve the case. Okay. Is the voice better now? Okay. Okay, so after we talk about this general, this rapid introduction, let's now talk about some important general pathological terms that will help us as we go through our journey in the pathology. First of all, what is or the development of the giant cells? So we hear sometimes the term giant cells. So what are the giant cells and how are they formed and what is their significance? When there is infection or when there is any kind of a tissue insult, this will stimulate the tissue macrophages. The macrophages which are normally located in this tissue. They are called the resident macrophages or the tissue macrophages. Okay, because that they are living in this tissue, they are sometimes referred as histocytes because they live in this histological section or this part of the body. So they are called the tissue resident histocytes or tissue macrophages. These are present in the uninfected state or unirritated state. Let's say that there any kind of inflammation or infection, this will result in activation of these macrophages. So this tissue or this insult or this organism will be engulfed by these macrophages. By the way, doesn't always have to be an infection. Sometimes it can be just normal fat, not just normal fat as what happens in xanthelasma. So the macrophages are engulfing become activated by the presence of fat. So it is not only or not always infection. It is can be infection or non-infectious cause, resulting in activation of this macrophages. Okay, when the macrophage is activated, they will proliferate. So when these tissue histocytes become activated, they will proliferate. And when they proliferate, they will be called epithelioid cells. Why they are called epithelioid cells or epithelioid macrophages? Because of their tendency to proliferate, they will look like as if it is epithelium. So they will call it an epithelioid macrophage or epithelioid cells. When these epithelioid cells fuse together, they will form the multinucleated giant cells. So multinucleated giant cells are formed by fusion of epithelioid cells. Epithelioid cells are formed by activated macrophages. Okay. So this is the uninfected state, and this is the infected state when there is infection. This will result in this cascade. So when this happens usually, and the presence of giant cells will denote that the patient will develop granulomatous inflammation. So this what will happen in the granulomatous inflammation, like in tuberculosis or sarcoidosis or in the or the conditions characterized by formation of granuloma, they will be characterized, the granuloma will develop by this sequence. So the question here is, the presence of giant cells is a must in order to judge a lesion to be granulomatous inflammation? No, it is not a must. But if it is present, it is granulomatous inflammation. If it is not present, it could still be granulomatous inflammation. So what is the hallmark of granulomatous inflammation? What is the indicator of the presence of sure granulomatous inflammation? It is the epithelioid macrophages or epithelioid cells. So the epithelioid cells, or the tissue histocytes, the activated tissue histocytes or activated tissue macrophages, are the hallmark of the granulomatous inflammation. Okay, so I want to illustrate this because this is very important and asked in the MCQ exams. Okay, so let's see now what are the types of giant cells. We have now the multinucleated giant cells. We have three types of giant cells. The first one is called the Langerhans cells. The Langerhans cells, it is a giant cells which is characterized by presence of peripheral ring. It is usually incomplete ring of nuclei, which will make this peripheral ring will resemble like a horseshoe. So this horseshoe pattern of nuclei in the cytoplasm is called Langerhans cells. Okay. So what is the next type? The next type is called the two-tone giant cells. Two-tone giant cells, in those cases of giant cells, there is a ring of nuclei. So there is a ring of nuclei. So how can we differentiate this ring of nuclei from the Langerhans cells? The ring of nuclei here in the two-tone giant cells is surrounded by eosinophilic cytoplasm. So you see this eosinophilic, or see this is a eosinophilic cytoplasm, the center, and the periphery is foamy lipid. You see, this is the foam. Let me highlight it. A foamy lipid present in the periphery. This is lipid, foamy lipid. So this ring of nuclei will separate a central eosinophilic cytoplasm from a peripheral foamy lipid. So you will now anticipate that this kinds of giant cells occurs in lipid disorders, and your expectation is correct that these kinds of cells or two-tone cells present in lipid disorders, and one of them is called the juvenile xanthogranuloma. Juvenile xanthogranuloma, it is a lipogranulomatous disease which will be characterized by lipogranuloma affecting the skin and the iris, and we are going to discuss it in the iris again. The third type is called the foreign body giant cells. And in the foreign body giant cells, the nuclei are centrally placed and overlap each other. You see here, the nuclei here are present in the center, not in the periphery, like in Langerhans cells and two-tone cells, and they overlap each other. They are haphazardly arranged. So to summarize, these are the granulomatous inflammation by presence of epithelioid histocytes. So these are the epithelioid histocytes. And this is the Langerhans cells with showing the peripheral ring of nuclei taking the horseshoe pattern. This is the two-tone giant cells, which occurs in juvenile xanthogranuloma, in which there is a ring of nuclei separating a central eosinophilic cytoplasm from a peripheral foamy lipid. And this is the foreign body giant cells, in which the nuclei are random. They are irregularly arranged. They are overlapping over each other and they present in the center. Okay. Let's see a very common example about the giant cells that are asked frequently in the exams. Apart from two-tone giant cells, it is the giant cell arthritis. We remember giant cell arthritis from neuroophthalmology. We talked about it, and we said that it can cause anterior ischemic optic neuropathy, arthritic anterior ischemic optic neuropathy. So what happens in the giant cell arthritis is that there is inflammation of the wall of the artery, resulting in occlusion of the lumen. So what can we see here? That there is thickening of the media, thickening of the adventitia, and fragmentation of the internal elastic lamina, and there is occlusion of the lumen. When we see a magnified picture of the wall of the artery, so this is the normal wall of the artery. You can see this is the tunica media, this is the internal elastic lamina, this is the tunica outer tunica adventitia, and this is the normal thickness of the wall of the artery in relation to the lumen. You see, this is a patent lumen. And the inflammation of the wall of the artery is what led to this narrowing of the lumen, which resulted in ischemia, as in ischemic optic neuropathy. So why it is called giant cell arteritis? Because it has giant cells. It is a granulomatous inflammation characterized by presence of giant cells. So if we take a higher magnification of section of this artery, we will find this. What is this? This is the giant cell. You can see the peripheral ring of nuclei taking the horseshoe pattern. This is a patient that has a giant cell. That's why it's called giant cell arteritis. Okay. So this is about the giant cells. Let's now talk about another topic, which is the skin lesions. And before we talk about skin lesions and eyelid lesions, we need to know again what is the normal histology of the skin. So the skin is formed by epidermis followed by a layer of dermis. So epidermis followed by the dermis. The epidermis is covered by a keratin layer. You see, this pinkish eosinophilic material is called the keratin. Then the epidermis is composed of three layers. The most superficial is called the granular cell layer, followed by middle prickle cell layer, and finally the junction between the epidermis and the dermis is there is basal cell layer. And why it's called the basal cell layer? Because it is based on a basement membrane. So the basement membrane is what is separating the epidermis from the dermis. In normal occasions, this basement membrane should be intact. If it is violated, this will denote an invasive carcinoma. There are important terms to describe skin lesions. First of all, the acanthosis. So let's see what are these terms referred to. First of all, the acanthosis. And what is the acanthosis? The acanthosis is the increase in thickness of the prickle cell layer. So you see here, this is a granular cell layer, and all of this is the prickle cell layer. So you can see that it is hugely thickened. This is called the acanthosis, increasing in thickening of the prickle cell layer. The next term is called the hyperkeratosis. And as the name implies, it means that there is increasing in thickness of the keratin layer. So you see, this is the granular layer, and all this huge eosinophilic material, this is the thickening of the keratin layer. Okay, so this denotes also hyperkeratotic lesions. A parakeratosis, so keratosis refers to keratin, and the para meaning that it is the keratin is present in abnormal location. And this is correct, that there is retention of nuclei in the keratin layer, or there is abnormality in the keratin. So in the keratin, it should be homogeneous, featureless, but in case of parakeratosis, there is retention of nuclei, this basophilic material, in the keratin cell layer. With this patient has granular layer absent. Finally, dyskeratosis. Dyskeratosis meaning that abnormality in the keratin. So what kind of abnormality? That it will be, the keratin should be outside the cells. But if there is intracellular keratinization, like if the keratin entered inside the cells, this means that the keratin is now, instead of being outside the epidermis, it's becoming inside the cells. So this is called dyskeratosis. Dysplasia. So what is meant by the term of dysplasia? This is the normal epidermis, but you can see this is the normal epidermis. However, or this is a case of conjunctiva, so this is an epithelium. And you can see that most of cells are of similar size but and similar shape, but here in this kind of this region you can see that the epithelium is not regular in size, not regular in shape, they are irregularly arranged. So this means that there is disorganization, and there will be like enlargement of cells, and this will, and even by micro, this is by light microscopy. If by higher magnification, when you examine the cells by electron microscopy, you may find even there is increasing in the nuclear chromatic ratio. You will see there is abnormal mitotic figures, which will denote that these cells are metabolically active. These cells are can show features of cancer, like these cells are not normal epidermis or normal cells. This is called dysplasia. So dysplasia is abnormal proliferation of cells, and that will result in presence of dysplastic cells, which are not typical cells. They are irregular cells. They are showing abnormal shape, abnormal color, abnormal size. But dysplasia is still meaning that these abnormal cells did not invade the basement membrane. So sometimes we refer to the dysplasia as a carcinoma in situ, that those patients will have dysplastic cells, but this dysplastic cells did not invade the basement membrane. If they are present, if these dysplastic cells are epithelial cells, we can call it carcinoma in situ. If it is melanocytes, we call it melanoma in situ. So these are termed dysplasia. So this patient has conjunctival intraepithelial neoplasia, grade 3 or severe neoplasia. This means that this patient this is a pre-malignant condition, that this patient will, or this patient has tendency or to develop malignancy. Okay, so we are ready to discuss the ocular problems and ocular